Stand by to fall in, Polk County. This is today's veteran. Hello and welcome, and on behalf of everyone at the Polk County Office of Veteran Services, thanks for joining us. I'm your host, Tim Kirkhart, and on this installment of Today's Veteran, we talk about suicide prevention awareness. In 2013, the United States Department of Veterans Affairs released a study that covered suicides from 1999 to 2010, which showed that roughly 22 veterans were dying by suicide per day, or one every 65 minutes. Joining us in studio today is Dr. Troy Howell, James A. Haley Veterans Hospital Suicide Coordinator. Welcome to the show.
Thank you.
Can you tell us about the program, what we're doing?
Well, suicide prevention at the VA has been around since roughly 2007. The Joshua Omvig Act is a national act through Congress that required every VA facility in the country to have a suicide prevention coordinator. Locally, we have multiple things we're doing locally, but the bigger issue is Secretary David Shulkin has made suicide prevention his top clinical priority within the VA. The latest research shows that 20 veterans per day are dying by suicide. Of those veterans, only 6 of them are actually seen within the VA system, and 3 of them are getting mental health treatment at any given time during that process. So what that means is we not only do we need our own VA programs doing what they can do, but also we need some help from the community to make sure that veterans are being recognized and also getting into the system as well. So. Bigger things we're doing, we recently approved expanded benefits for other than honorable discharge veterans, and that's a big issue that comes up for veterans who have an other than honorable discharge, but still need services within the VA.
Okay, so what are you doing at James Haley specifically?
Well, I'm the suicide prevention coordinator, and I represent a multidisciplinary team. I have myself, who's a psychiatrist, a psychologist, 2 social workers, 2 mental health counselors, and 2 nurses. And as a team, our job is kind of multifaceted. What we do is we provide education for the staff as it relates to suicide prevention. We also do 5 community outreaches at a minimum per month. That involves mental health summits. It involves going out to homeless stand downs, going out to Sun and Fun here in Polk County. We do a lot of things to sort of spread the word of what we do at the James A. Haley Veterans Hospital from a mental health perspective, but also what we can do from a medical perspective as well. In addition to that, we provide case management for our high-risk veterans. So a big part of our clinical responsibility is to identify those that are at higher risk and provide them with a little additional support in relation to what they're getting outside of suicide prevention. As a whole, our facility has a general mental health clinic where we see kind of anyone who has mental health issues and needs to be seen. We also have subspecialty clinics like PTSD and substance use disorder clinics. Substance use disorder clinics, you can be seen same day if you need to be seen. So we're doing a lot of things to expand our coverage. We're doing a lot of things to provide more services to veterans who need it.
I know when you make the phone call to any VA health situation, they always mention the suicide. Mm-hmm. What would happen, run us through what would happen if somebody calls in crisis? So
the Veterans Crisis Line is 1-800-273-8255, and veterans are going to press 1. That's going to take them directly to Veterans Crisis Line. The process from that perspective is the Crisis Line is a national hotline. It's staffed in Atlanta, Georgia, and upstate New York and Canandaigua, and a veteran will get a responder 24 hours a day, 365 days a year. They're going to deal with the crisis in the moment. So whatever the veteran has going on at that moment, the responder is going to help them get through that process. Up to this point, since 2007, the Veterans Crisis Line has received over 2.8 million calls, has done 74,000 emergency rescues. So whatever that crisis is in the moment, the responder is going to respond to. If the veteran needs immediate emergent care, that's going to be dealt with on the phone at the time. If they need follow-up the next day, that's going to be referred to us. And our team locally are the ones who respond to that. So we're going to have a responder within 24 hours or a case manager within our team that's going to call back to that veteran and make sure that they're getting the services that they need.
So if I'm at the local CBOC, say in Lakeland, and I'm seeing any of the healthcare professionals, they're, as you said earlier, they're trained to look for, what are they trained to look for?
Well, it depends on the individual situation. So if a veteran comes in for a mental health evaluation, they're going to get a overhaul. They're going to be looked at for pretty much any mental health issue that's happening. So if they come in with something like PTSD, that's going to be found out in that first initial evaluation. And the care is going to be tailored to the individual veteran. So if they have depression, if they have anxiety, if they have a psychotic disorder, those things are going to be dealt with accordingly to the veteran, as opposed to sort of a one case fits all type of mentality. Once that evaluation happens, they're going to be referred to the appropriate provider according to what they need. If they need more subspecialty clinic, somebody in Lakeland may be referred to the Tampa facility, but most of the time that their care is going to be taken care of in-house at the CBOC.
Okay. I once had a situation. I was doing veteran service work. I was at the vet center, VA vet center,
Yeah.
and I had an individual who was in mental crisis. And so we called in one of the counselors there.
Okay.
And he took over the situation. Of course, I wasn't really qualified. Is that common within the system?
That someone would be sort of a warm handoff?
Yeah.
Absolutely. So depending on the facility, if somebody's in their primary care visit and the primary care physician or provider feels the need for emergent mental health treatment, depending on the facility. If they're at the main facility where the ER is open 24 hours a day, if they're at the local CBOC, typically they're going to work together to get that person evaluated same day. If there's person doesn't want to wait and just wants a consult, then that'll be handled accordingly. But if somebody needs to be seen immediately, I've can't say that I've ever seen somebody walk out of a clinic without being assessed by a mental health provider if the primary care physician feels it needs to be done immediately. If the primary care physician has a different opinion or feels like that can wait, then a consult is entered, and depending on the situation, will be seen accordingly. So in our local mental health clinic, recently we had a call to the Veterans Crisis Line, and the veteran needed to be seen and had an appointment within 2 days. Now, that situation wasn't emergent, but they wanted to be scheduled. We got them in within 2 days. So the quality and sort of the frequency of the mental health care is tailored in some level to the individual in the sense of what needs to happen for that individual. The timing of the appointment can be as early as same day or as late as 14 days if that's what the veteran desires. So a lot of this is based upon veteran input in the sense that if they want to be seen next day and they can do that from their availability standpoint, that's what's going to happen. If they have something or they have work or they can't get there for the first 10 days, then we'll schedule accordingly to that.
Okay. Can you tell us what the, I guess the diagnosis, I'm thinking we're always talking about PTSD, which is a form of this system. What about anxiety, depression? Are those the most common, or?
Well, depression is the most common overall. Just from a frequency standpoint, in this culture, depression happens more often than any other diagnoses. Now, I would venture to guess that a lot of people out there have what we would call subclinical anxiety or subclinical depression at times, where they're not going to meet every criteria for a diagnosis, but they're pretty anxious because of their social stressors, or because they have an event coming up, or because they have lost a loved one recently. That anxiety is normal, right? So depending on the situation, how much that affects their daily functioning is where the diagnosis sort of goes from being sort of a human emotion to an actual disorder. Depression, people that have depression typically have their sleep affected. They lack interest in things they used to enjoy. Their energy level is not quite as high. Their concentration is affected. Their appetite can be affected. That's when suicidal thoughts can come about. And depression, anxiety are two of the major sort of risk factors that we look at for a person that has the potential to die by suicide. So we're going to look for those sort of diagnoses to make sure that we're ruling out some of those things that kind of escalate their risk. Depression and anxiety aren't the only things that are associated with risk when it comes to suicide. Things like agitation, which can be associated with multiple disorders, it's not just one. And agitation can be not necessarily anger, which a lot of people, when you hear the word agitation, you think somebody that's angry. It's more about sort of maybe being short-fused or not wanting to do things, or maybe acting impulsively. And sort of agitation from a clinical perspective is more on edge, is kind of the way I look at it.
Can you tell us about a program or method? It's called TMS. Mm-hmm. What is that for, and how does that work?
So transcranial magnetic stimulation at our local VA, I believe we're the top national producer of TMS at this point. TMS currently is approved for depression. It's currently being studied for also to also treat PTSD. We're in the middle of that research on some level, and the idea behind transcranial magnetic stimulation is they put magnets in certain places on your head and send a magnetic sort of charge that affects the neurons and the transmitters in those specific pathways. By doing so, you help somebody improve on their depression, get them close to recovery, and ultimately help to reduce their symptoms.
Is that a new?
Yeah, it's a newer process. It's been happening for, I would say, several years, but newer to the VA and newer to really being approved, not just the VA, but just wholly as far as TMS goes. And TMS is a very sort of non-invasive process. Other processes that psychiatry has used in the past to help with depression are a little bit more invasive and require a little bit more downtime. TMS is something that can be done in an outpatient setting. It's not invasive, doesn't cause pain, doesn't require anesthesia or anything along those lines. It's a precursor to a lot of the heavier treatments, and hopefully if TMS works, none of those are needed.
So is that an ongoing treatment?
It can be. It's an individualized sort of setting. There's typically a standard beginning, but the continuous process depends on the reaction to the actual treatment.
Okay. Everybody wants a statistic. Where would James Haley fit in maybe the ranking of mental health?
Well, as far as mental health goes, we're top 20 nationally. The context of statistics is, in some level, is the eye of the beholder, and what I would claim even beyond that is what we're really good at is getting people in and getting the right treatment. Whether we're ranked top 20 or not is not as crucial to me, because what I see from my job at the VA is when we get people into treatment, when they're getting the care they really need, they get better, and ultimately we reduce risk dramatically with people that are investing into care and getting the treatment that they need.
Well, Dr. Howell, we're about out of time for this segment. Can you stick around and talk some more with us?
Absolutely, I would love to.
We will be back with more of today's veteran right after this.
I've never been the type to ask for help, but I had enough.
Thank you for calling the Veterans Crisis Line. How can I help you?
Life still has its challenges, but my family and I can deal with them better now. Veterans Crisis Line. It's your call.
Welcome back to today's Veteran. I'm your host, Tim Kirkhart. The James A. Haley Veterans Hospital has a wide range of mental health services available to veterans, inpatient and outpatient settings, and diverse locations. A program at James A. Haley Veterans Hospital that is making a difference in veterans' lives is the James A. Haley Suicide Prevention Team. The team works with veterans in crisis to ensure that they receive enhanced levels of mental health care, and they have access to all the tools and resources necessary to resolve their crisis and maximize their overall level of functioning. We're back with Dr. Troy Howell, James A. Haley VA Medical Center Suicide Prevention Program. Welcome back. We appreciate you coming back.
Thanks for having me.
Dr. Howell, could you tell us how to recognize some of the signs of possible suicide?
Depression and anxiety is, again, to sort of repeat that on some level, is one of the clinical things we look for as a higher risk potential. And to take it out of the sort of clinical mindset in a sense of trying to diagnose a specific disorder, we really look for symptoms, things like hopelessness or helplessness, or people feeling like they're not enjoying things they used to anymore, or sleeplessness, meaning they're not sleeping as well, or they're not going to bed as early as they used to, they're waking up before they used to, or they're not sleeping at all. Those are signs of depression and can be signs of anxiety as well. The bigger sort of risk factors that we worry about are social isolation or social withdrawal. So, you know, somebody that used to be the social butterfly and attend coffee every morning with his buddies is now not doing that anymore, or is, you know, coming only once a week, or, you know, has decided not to have those communications that they used to with their friends. And then some of the later risk factors we worry about are agitation, and again, not necessarily anger, but just sort of on edge and maybe being a little bit more likely to do some impulsive things. Impulsive behavior is another one, that if people are taking risks that they used to not take, driving faster, not wearing a seatbelt, and those are sort of soft signs, but things like maybe drugs that they never took before, or drinking more than they used to, or going out at all hours and they used to not do that. If there's a big change in somebody's personality, whether it be more energy or less energy, those can be concerning. Now, that should be taken in with sort of a global picture of that person. It shouldn't be, you know, they went out on a Friday night and that means they're at risk for suicide. But if that becomes a process that they're changing and it's being different, somebody may want to ask a question to that individual. And it gets back to the biggest sort of changes, or the biggest sort of interventions that we have are typically from friends and family. It's not always the clinical provider that makes the change. It's usually somebody within their life that asks a question, that brings up an issue that potentially that veteran or that person's already thinking about, but hasn't seen it affect somebody else in their life. And once that happens, that typically initiates their drive into getting treatment. So that's a big part of this, is when somebody sees something that they're concerned, don't be afraid to ask the question. This past September, we had a Suicide Prevention Month is in September, and this past September, the national sort of push was #BeThere. And sort of the meaning to that is not necessarily be there like in the moment of be right next to the person. It means be there for them for whatever is necessary. If they need to go to coffee to have a discussion, if they need to, if the question needs to be asked, if they just need somebody to put their arm around them and say, I care, those are sort of the meanings between be there. It's not necessarily, you know, you have to be there at every moment. It just means be there when the person needs you, and ask those questions. There's another national push from the National Suicide Prevention Lifeline called Be the One To. And I kind of like both of them. It's hashtag Be the One To. And Be the One To, it kind of refers to that, be the one to make the difference. Be the one to do whatever needs to be done. So friends or family, if you're seeing people that are having issues, ask that question and talk to the person and encourage them to go talk to somebody. And they may not need long-term mental health care. They may not need 95 sessions. They may need 3 or 4, but that could make their sort of course go from potentially becoming at risk for suicide to actually gaining recovery from whatever that ails them at that moment.
What about the situation where you maybe you don't see any signs? Some of the killings and stuff that we see, nobody says they see any problems. How difficult is that then?
Well, obviously that's when these are unpredictable and these situations happen sort of out of the blue. There's not a perfect scenario. I think creating awareness and making people more aware of risk factors and things that they should be looking for may potentially help with that. But there are situations where people die by suicide without ever seeing a mental health provider, but typically they're seen by somebody in the healthcare field. Half of people who die by suicide are seen by their primary care within a year of their death. And so the process is, primary cares need to be aware. We need to create awareness for suicide prevention, not just in a mental health realm and not just in a VA realm. One of the statistics I've heard that sort of is eye-opening to me, the World Health Organization has estimated that there's a suicide every 40 seconds around the world. That's a huge non-VA population in this world, but locally, when we turn it back to the VA population's at higher risk based upon being in the VA and the veteran population. And so we have to create awareness amongst anyone that comes into contact with pretty much anyone, but specifically veterans in this situation, to encourage them to get into the VA and encourage them to use the VA's resources to get them into recovery if they're having issues, or just get regular health care, and if those situations are happening, then hopefully it's seen prior to. The thing I would say is if a veteran is unaware of these things happening and the moment starts to have these thoughts, the Veterans Crisis Line's open 365 days a year, 24 hours a day. It's a great resource. If you're a younger veteran and you want to do chat, there's chat online, veteranscrisisline.net / or / I can't remember which one, chat. And also there's a text line, 838-255. You can text 838-255. I'm in crisis, and a responder is going to text you, just like you were on the phone, but is going to do it through text. So it's a little bit more anonymous, a little bit more comfortable for some folks, and that's a way into resources. So I would tell people if they're starting to have thoughts like that, especially veterans, the first thing to do is 1-800-273-8255 and press 1. Responder will help you in the moment, and they will get resources in reaction to that.
What happens if they're on a chat line and things are getting pretty hot and heavy, and all of a sudden they stop, they get off of the chat line, and you don't actually probably know who they are or anything?
Well, so the National VCL or Veterans Crisis Line will access that stuff early on. So as a responder, the job of the responder is to find out who they're talking to and find out where they are. So in that scenario of emergency, they have access or they have a way to find the person if necessary. The VCL does a lot of sort of detective work's probably not the right word, but they have relationships with law enforcement. So if it's necessary to find somebody, if anybody's seen the HBO documentary, there's an example of that where I believe the veteran's in Hawaii and calls and the phone cuts off and they ping his phone and they're able to find him and he's safe and it kind of works out. But the crisis line is very proficient in doing those things. So if an emergency is necessary, they're going to get the emergency personnel they need involved to find the person. They do what's called a welfare check, and they'll send police to the person's house. Typically, that's going to be communicated to the veteran. So if they're feeling the emergency services need to happen, the veteran's going to be aware of that before emergency services show up. In the situation you're speaking of, it becomes we don't know the answer. We have to save this person because we don't know what's happening. So ultimately, the caution side is where the VCL tends to lean. Locally, we respond to what happens afterwards. So if emergency services are put out to a person's house and they're deemed to be safe by emergency services, we're going to be the people that follow up with them, so that it's not just an end point at when the emergency services go out. We're going to follow up with them, and if they need treatment or they need to get into help, or they aren't VA, they aren't enrolled in their local VA at that point, we're going to help that process. We're going to make sure they get through eligibility. We're going to get them enrolled, and we're going to get them into the treatment that they need. So again, the crisis line is a great starting point for a lot of folks. In general, the crisis line should be used for suicidal crisis. And with that being said, that suicidal crisis could be a variety of things for a variety of individuals. So it may not just be somebody who's suicidal. It may be somebody who's severely depressed, lost their job, potentially going to lose their house, and they don't want to get to a point where they're getting to the process of thinking about suicide, so they call the crisis line early on. That's perfectly fine. The idea is to help people that are at risk, and anybody's crisis is individualized. So if your crisis is for X, Y, or Z, we're going to help you with that.
Okay. We're about out of time. Do you have any parting information that you want to give to our audience?
Sure. I mean, again, to repeat, 1-800-273-8255, press 1 for veterans, is crucial for everyone to know out there. Pass it along to people, pass it along to fellow veterans. The idea is to create awareness amongst those that are at risk. A VA population is at risk at a higher frequency than those that are not veteran. So the more people that are aware of the resources, the better we are as a population, as a culture, to help save the people that we need to save. So the context is be there for your fellow person, specifically be there for your fellow veteran, but 1-800-273-8255. It's critical that everybody knows that number. Everybody, if you don't know how to press 1 at the end of it, at least you got the number, and 1-800-273-8255, not to be redundant.
Okay. Well, Dr. Howell, thank you for being on the show today.
Thank you for the opportunity. I really appreciate it.
If you need more information about Veterans Suicide Prevention Team, give the Veterans Crisis Line a call at 800-273-8255 and press 1, or look them up on the web at www.veteranscrisisline.net. That's going to do it for this edition of Today's Veteran. I want to thank our guest today, Dr. Troy Howell, but most of all, I want to thank you for joining us. Remember, for help and information regarding claims, benefits, and services available to veterans and their families, call the Polk County Veterans Service Office at 863-534-5220, or log on to the Polk County website at polk-county.net. I'm your host, Tim Kirkhart, and we will see you next month.